You're forming more cells that are going to be crunched into a smaller area.
So looking at this, you can't tell. This is just a high magnification to show you that these cells look normal. That's going to be looking at the big picture. You're going to see, usually your glands are just lined about, but they're not forming a mass. But you'll be able to see that it's forming a mass, both grossly and on low magnification under the microscope. And you can see the big picture. You can see the the haired skin, if you kind of got some of the haired skin with it. And usually with tumors, they're going to be expanding the surrounding tissue. And usually with benign tumors, if they're benign, with benign tumors, they're going to have a capsule. So all those things tell you it's a tumor. Okay? And it's a tumor because you have excess growth of these glands, but they're forming a mass. Any other questions? Yes.
This is, you're going to kill me for asking this. Have you ever heard in dogs that these are androgen dependent, the perianal gland adenomas?
So this is not a perianal gland
Oh,
adenoma.
it is not? Okay. Okay.
So perianal gland adenomas are definitely androgen dependent. Definitely. Like that's known. If you have, and perianal gland adenomas are also called hepatoid adenomas or circumanal gland adenomas. They're all synonymous. But this is the anal sac. This is what's they have, the little holes, the little ducts on either side of the anus where you have to extrude or express the anal sacs. That's what this is. It looks complete, and we're going to look at circumanal glands, but they look completely different. So circumanal glands are actually modified sebaceous glands, and they look like hepatocytes, which is why they're called hepatoid adenomas. So we'll talk about those. And those are usually benign, but they can be malignant. Anal sacs, actually, their tumors are usually malignant. And when you have an anal sac adenocarcinoma, it is not good to have because those are very aggressive. So you would want to catch that very early and remove it and kind of pray that it hadn't already spread. Okay. But the point I wanted to get with this was these cells look normal. That's what benign tumors look just like their normal counterpart cells. They're just forming a tumor. Yes.
So with hyperplasia, the cells grow, but then eventually they'll stop.
Yeah.
So is it safe to say that with this one, you can differentiate between neoplasia and hyperplasia because this one will continue to grow?
So benign tumors tend to stop also, but a hyperplastic response is just that. The cells are just hyperplastic. They're not going to be forming an expansile mass, pushing the normal tissue away, because it is normal tissue, it's just hyperplastic. But this is forming the actual mass. Okay. And one other thing I can point out here is that these epithelial cells are called the parenchyma, and this stroma in between it is called the stroma. Okay, these little nuclei are probably like fibroblasts. You may have like a macrophage in there or something. But. Okay, any other? Yes.
I may have missed this, but why does it end in coma and it's malignant?
No, this is benign.
Okay.
So I'm going to repeat it again to make sure we're all clear. So I said most anal sac tumors are going to be adenocarcinomas, but you have benign and malignant. So this is benign, and the reason I picked this picture is because it's a great example of a tumor whose cells look perfectly normal. It's very well differentiated. If you had a lower magnification view, you would see that it's not infiltrative. It's just this single growth that's just kind of there. Is everybody clear why I put this as an example of a benign tumor of glandular origin, an adenoma? And again, from this magnification, this looks just like the normal cells will look. You can't even tell it's a tumor. You just think it's anal sac unless I told you otherwise, because it's benign. Okay, so again, talking about tumor names classified based on the appearance of the cells and the appearance that grossly sometimes. So adenomas you can tell because the cells are forming glands. Okay, papillomas is another example where you can tell what it is because you have these finger-like projections coming off of the epithelial surface or the epithelial surface is forming finger-like projections. They are the neoplasm. But it's just the fact that they're forming finger-like projections that make you call it a papilloma. A lot of times you can tell this grossly and microscopically. So this is an example of a papilloma microscopically. I think I have a really good, some pictures I took of some biopsies. I'm gonna put it in here of these perfect little papillomas. But anyway, this will look the same on gross section. You have these finger-like projections, outgrowths of the epithelial cells, benign papilloma. Any questions on that? Okay. Polyps, another one that you can classify strictly based on its appearance. It's a neoplasm that projects above a mucosal surface. So the word there's colorectal polyps, nasal polyps, pharyngeal polyps. So these are benign neoplastic growths of mucosal epithelial cells. Okay. Any questions on that? All right. Cyst adenoma. It's one of these forming cysts. Something that glands sometimes do. So this is an apocrine cyst adenoma. So just like an adenoma, except the spaces are more cystic. It's just a nomenclature characteristic. Okay, so that's like your nomenclature of benign tumors. So now we're going to talk about your nomenclature of malignant tumors. Malignant neoplasms arising in mesenchymal tissues are called sarcomas. I think we have that clear. Some examples that are listed are fibrosarcoma, so malignant neoplasms of fibrocyte origin, or fibroblasts become fibrocytes. So if you hear fibroblasts or fibrocyte, you're talking about the same cell, just less or more mature. Liposarcoma is the neoplasm of adipocytes. So usually, like, you'll see lipomas all the time because older animals get them, older people get them, but they can also be malignant. So, you know, it's not a bad idea to take them off. A lot of times in older animals, clinicians won't because they're old. It's probably, you know, lipomas are usually freely movable in the subcutaneous tissue. So you just use your best judgment, kind of. If there's any reason you need to be concerned, if so, take it off. If not, most people don't want it, especially old animals. Malignant neoplasm of epithelial cell origin are called carcinomas. Squamous cell carcinoma is a very common tumor. So that's malignant tumors of the stratified squamous epithelium. So the skin, the oral cavity, get in there. A common place for squamous cell carcinoma in the horse. Do y'all know where that is?
The non-glandular part of the stomach.
The non-glandular part, and specifically where? Yeah, the Margo plicatus. So that's pretty common in the horse. You get squamous cell carcinomas of the penis, the penile sheath. That's kind of common in the horse. Do y'all know one of the most malignant or common malignant tumors in the horse? This isn't it. Particularly gray horses. Sarcoid actually probably is the most common. I was just in my head thinking of melanoma. Sarcoid is very common. That has to be the most common. We see that all the time. But another thing we see all the time, particularly in gray horses, is melanoma. And usually, where do they usually originate? The perianal region. Adenocarcinoma is the other example. Malignant neoplastic cells that grow in a glandular pattern. So this is kind of a stereotypical mesenchymal cell appearance. They tend to form, they are usually spindle cells, or they form spindeloid cells and have spindeloid nuclei. So if you see this, there's no way this is an epithelial tumor, so you would call it a sarcoma, even if you couldn't figure out exactly where it's from. The less differentiated a tumor is, the less easy it is to tell the cell of origin. And if that's the case, if it's that anaplastic, that they just look like malignant cells, what we usually do is we'll say malignant epithelial tumor or poorly differentiated carcinoma or poorly differentiated sarcoma. And then, because we still want to find the answer, we'll do immunohistochemical stains based on, what our differentials are, based on where it is, the history, what we think it could be, based on the cell type. Usually we can kind of narrow it down to something. Like a good example is leiomyosarcoma versus rhabdomyosarcoma. They're both tumors of muscle origin, so myo, muscle. And so we'll do stains to like, which one is it? And that's important because, we don't, as pathologists, we don't really deal too much in the treatment aspect of things. We're more diagnosing. But you have, especially oncology, you have all these protocols for specific tumors that research has shown is effective. So it's important for us to give them an accurate diagnosis. So we do whatever we need to do to figure that out. And usually when you can't tell histologically, just under routine, like microscope, you go to immunohistochemistry. And there's lots and lots and lots of antibodies and markers to pinpoint which cell of origin it is. But what I really want to show you here was this spindle appearance. With mesenchymal cells, you tend to not be able to differentiate the cell borders, or the cytoplasmic or cell borders are indistinct. You can't tell like one cell to the next. Epithelial cells you usually can because they have those cell-to-cell junctions that kind of allow them to be more defined. But the more anaplastic it is, the less likely you can tell a lot of stuff. So what are these right here?
Is it fibrous?
Here. So here's the nucleus. This is a nice normal nucleus. But then you have these little dark linear structures. This one is kind of separating.
So mitotic cells?
Yeah, mitotic figures. This one has like 3 little poles. So this has a high mitotic index. Mitotic index is one of the features that you can use to determine that, not always, some benign tumors have a high mitotic index, like cutaneous histiocytoma. But a lot of times, that's one of the features of malignancy, high mitotic index. And this one had a lot of mitosis. The nuclei aren't that clear, variable in size, but there is some anisokaryosis, which means variation in nuclear size. So this one is pretty big compared to like this one or any other. So you do have some variation. So that's another feature of malignancy. So is everybody clear on differentiating this as a mesenchymal tumor from, could have probably just said it, I didn't know it was this far back. From this as an epithelial tumor? Okay. That's what was the point I was trying to get across. Okay, so sarcoma. And just to kind of compare a normal mesenchymal cells from this. So here you have a lot, the cells are very densely compacted. Your nuclei are very close together. You don't have that much production of whatever their product is. So let's say this is smooth muscle tumor. I don't think it is because the nuclei aren't blunted. This is probably a fibrosarcoma. But at any rate, in normal tissue, usually because it's well differentiated, it's producing something. Fibrocytes are producing collagen. Smooth muscle cells have abundant smooth muscle cell cytoplasm. So here, you have very well-spaced nuclei. They're not all on top of each other because they're not just growing like tumors do. They're very uniform. Okay, so this is normal smooth muscle and what a normal mesenchymal tissue would usually look like, very organized compared to this. Low mitotic index, there's no reason for them to be dividing. Okay, is everybody clear on that? All right.
Which one has low mitotic index? This one?
Normal, like
normal.
differentiated cells that are where they need to be They occasionally will mitotically divide, but they're not a rapidly growing cell population. They're just normal cells where they need to be. So like, can y'all tell me where this is? So you have,
GI?
yeah, GI. You have your inner circular layer, and your outer longitudinal layer, and just based on the way it's cut, you cut it in cross section, so your circular layer is going to look longer, and because you cut it in cross section, your longitudinal layer, which is going like along the length of it, is going to look like transverse sections. So yeah, and then you have your Auerbach's plexus, which is also called your myenteric plexus. It's between your inner longitudinal layer and your inner circular layer and your outer longitudinal layer. So that's another word you can know. And then your serosa and your mesothelial cells. Okay, I want to go over time. So that was sarcoma. So this is an example of a carcinoma, which is an epithelial cell origin. Probably should have put the normal first. So let's go to normal and then abnormal. So this is normal epithelium, stratified squamous. And do y'all know the layers of your like skin? So let's start from the bottom. Stratum basale or basal layer, yes. And stratum spinosum. Stratum granulosum. And what would be on the surface? Stratum corneum. Very good. And this is obviously is a non-keratinizing surface, but if it was like the epidermis, you would also have keratin. Okay, so this is very normal. You have nice polarity where everything is just lining up just the way it should. You have a basement membrane. This yellow line is representing where the basement membrane would be that your cells rest on. And then underneath, you have this, because this is probably a mucosal surface, so you have your submucosa, which is usually just kind of stromal cells, fibrocollagenous tissue. If it was the skin, the epidermis, then if this represented epidermis, then this would be where your dermis is. But all of the cells are respecting their boundaries. They're lined up against the basement membrane. Everything is nice and uniform. Your layers are doing what they're supposed to do. So that's normal. So abnormal, or malignant tumor of epithelial cell origin, does whatever it wants to do. So here's an example where you can see like the differentiation between the epithelial cells and the stroma. Like, so this is a basement membrane, but then you have this, it's just coming right through. There's no organization, so you have a loss of polarity. When things are disorganized, we say loss of polarity. So just on low magnification, without really looking at cellular details, you should be able to tell this is a malignant tumor of epithelial cell origin. They're not spindeloid, they don't look like mesenchymal cells. You can even see from this magnification the cell borders. So this is characteristic of epithelial cell. Is everybody clear on this? All right, and these are just kind of some things that don't really read the book, or you kind of just have to know it. You can't figure it out by, oh, this is epithelial and origin, and so we're going to go over those kind of idiosyncrasies with nomenclature. This is not bad. This is just saying that benign or malignant tumors are clonal, something to think about. All the cells are going to resemble each other because they all come from the same cell of origin. There are some tumors that are going to be mixed, where you have like two cell lines, two different cell types in there. It's either because, and usually it's due to a metaplastic change that's common in mammary tumors, where you have your epithelial glandular cells, and then you have some cartilage over there. Like an example of that is a mixed mammary gland adenocarcinoma. But for the most part, the cells in most tumors are going to look just the same. I mean, there'll be variation like the cell size, cell shape, but they're of the same origin. So they're clonal. They come from one it originates with damage to one cell, and then they progress from there. Cells that do have other cell types in them or mixed tumors are called pleomorphic versus monomorphic, where the cell types look the same. So a teratoma is one of those words that you just have to know. And a teratoma represents a tumor that arises from totipotent cells. So it's usually going to be in the gonads. And so in teratomas, you have all three of your embryological layers. So you have endoderm, mesoderm, and ectoderm. And because it's derived from totipotent cells, that means it can be anything. So you have this big ovary from a dog or a cow, and you look at it under the microscope, and you'll see bone and hair and neural tissue and skeletal muscle and anything and everything. And you know it's a teratoma. Teratomas are usually benign, but they can be malignant. If it's benign, you say benign teratoma. If it's malignant, you say malignant teratoma, because there's no other suffix to put on the end of that. That's the same for some other things, but not coming to my mind. So I just thought of another example of that. So melanomas. Melanomas are of neuroectodermal origin. And if you have a benign melanoma of the skin, you call it a melanocytoma. If you have a malignant melanoma, even though it ends in oma, you call it malignant melanoma. That's another example where that rule doesn't apply. Okay. And we've already talked about the fact that sometimes the tissue of origin is difficult to identify when the neoplastic cells are poorly differentiated. So they look like, embryological cells sometimes, and you have no way to know until you do immunohistochemistry.
Dr. Gilman?
Yes.